how you choose to act upon trade-offs. I think that scientists took away the choice from people through this pandemic, through misleading messaging, being overconfident, and falsely articulating the trade-offs. If I tell you if schools were open, all the kids would be dead, you would say, close the schools. But if I told you the reality, that the risk to kids is so very, very low, and the risk of closure is so very, very high, you might choose differently.
Mainstream media gives you the impression that there is nothing good about America. In direct contrast to that, my podcasts will prove by examples that America has always been and still is the land of opportunity for everyone.
Hello, and welcome to another episode in the series Life Lessons with Dr. Bob. My guest today is Dr. Vinay Prasad. Dr. Prasad is a professor of epidemiology and biostatistics at the University of California, San Francisco. In addition to teaching, performing research, and writing papers, as a hematologist-oncologist, he also cares for cancer patients at the San Francisco General Hospital and the San Francisco VA Hospital. He is the author of over 400 peer-reviewed papers, including articles in the New England Journal of Medicine, Nature, and the Annals of Internal Medicine. He has also written 2 books, published by Johns Hopkins University Press. In addition to his publications that are geared for medical professionals, his views on medicine are also of interest to the general public. In that regard, Dr. Prasad has written over 100 op-eds that have been published in media outlets including the New York Times, the Washington Post, and U.S. News and World Report. In addition to writing, he has also expressed his views on the practice of medicine as the guest on numerous podcasts. And now he can add this one to his list. Welcome to the show, Dr. Prasad.
Thank you for having me, Dr. Bob. Pleasure to be here.
Let's start with a simple question. The UCSF website says that your first name is Vinayak, V-I-N-A-Y-A-K, but other references that I found say that it's just V-I-N-A-Y without the A-K. Which is it?
Well, my full name is Vinayak with the A-K, and I go by Vinay, and it's sort of like Jonathan John. So that's sort of, makes it a little bit easier. But to be honest with you, when I was in high school, a lot of people used to call me Vinny or V, or even by my initials, VP. So,
That's good. Being a VP is always good.
It's always good.
Now, reading on your bio, it says that you carry out research into evidence-based medicine. What does that mean? Isn't the practice of medicine based on evidence?
It's a great question. And I think to some people, evidence-based medicine sounds redundant because if you're not basing it on evidence, what were you doing?
Witchcraft.
Voodoo. Really?
Right, yeah.
And I think the truth is, in the history of Western medicine, we have to acknowledge that for thousands of years, the type of medicine people practice was largely driven by theories of how the body worked, maybe about bile or black colic or different fluids in the body, blood and bile. They were based on what your boss taught you. It was a sort of an apprenticeship model, and people learned what was the way to practice medicine based on the eminence of their teacher. It's almost an era of eminence-based medicine.
Mm-hmm.
And it wasn't until, in the 20th century that we started to do more controlled clinical experiments where we really tried to sort out, how well do therapies work versus the alternative versus doing nothing. And the revolution of evidence-based medicine was really in the 1990s, where people realized that a lot of the traditional ways in which we thought about the body, trying to reduce it to the mechanistic parts and reason upward, could sometimes lead you astray. And so we needed to sort of approach medical questions by thinking first and foremost about the patient, their desires, their goals, and then the choices that they face and the evidence that supports those choices. And to some degree, it has been sort of a renaissance in medicine in the last 30 years.
In 2015, you co-authored a book entitled Ending Medical Reversal. What does that mean, ending medical reversal, and why do you want to end it?
So That's a good question. Anybody who follows medicine will feel as if doctors flip-flop. We recommended doing one thing for 10 years, and then 10 years later we say, do the exact opposite. Don't eat eggs, it's bad for you. Oh, eat eggs. Don't eat butter, eat margarine. Actually, got that the other way around. Those are the sorts of things that it feels like dominates the news cycle. Mm-hmm. It turns out even in the practice of medicine, that happens a lot. We were stenting people with angina and blockage of the arteries with a coronary stent, and people thought that we're reducing their risk of heart attack and improving their longevity. A few years later, we learned that's not true. So,
is that the case now, that stenting is not the preferred method of handling blockages?
So I'll draw, just to be very clear, blockages can range from a severe blockage that happens in a minute, that's a heart attack, to a blockage that's a slow buildup over time. And the severe blockage still benefits a lot from stenting, but that slow buildup was also stented, and that doesn't appear to benefit as much, if at all.
Oh, how interesting. Because I just had a friend who had an angiogram, that's right, following some procedure. And while they were there, they asked him ahead of time, while we're in there, if we see blockages, should we put stents? And he said, sure.
Sure. You're in there anyway.
Yeah, but they were only blocked like 30 or 40%. And he's not young, so you don't have to worry about him, about 40 years what's going to happen. So it probably was incorrect for him to say do it anyway.
I would say that the evidence for that might be rather weak.
For doing it.
Ooh.
Okay.
Okay, so that's what we're talking about. We're talking about, I think this is a great example. When the person goes to the doctor and they offer a stent in this situation, I think that the patient believes that it's got to improve my longevity or my quality of life. And when later on it's found through better studies that it doesn't do those two things, I think some people might feel cheated. They might feel like, the doctor led me to believe, or I was under the impression it was going to help me avoid heart attacks and live longer. It turns out both those things aren't true. And that's what we call a medical reversal, where we were doing something, we really were extolling the virtues, we were praising it, we were getting people to do it. And then later we find it actually doesn't do the good thing we thought. And to me...
So was the initial conclusion that it was good? Was it based on poor tests or incorrect analysis of the data?
Yeah, I think it was based on the fact that it's logical that it might help. It's narrow there. It's logical that would be the place where the heart attack might occur. It's seductive in the sense that we have this thing that can do it.
Open it up.
We can open it up.
Right.
It's plausible. We can do it. And then we start to get into the financial side of it and the doctor side of it, which is that
makes money.
It makes money. And the person you do it on often says, I feel better. They come and tell you, I feel better, doc. Thank you. And as a doctor, there's nothing more gratifying than the patient telling you, I feel better.
Happy patient, right.
Happy patient.
Right.
So you pay.
But I suspect that there's a placebo effect in there somehow, because you'd feel better even if, let's say, he said he did it, but he didn't do it. You can still come back and say, I feel better.
And in fact, that what you said right there is a 2017 study called Orbita. They later followed up the study and they said they did it, but they didn't. And they showed similar improvements in
patient happiness.
Right.
And that was about stents?
It was about stents, modified Bruce protocol treadmill. I mean, it was a more technical thing, but it's the same thing.
Same idea.
Same idea.
Whoa.
You're absolutely right. So it is an effect. It's a real effect, but it's the effect of the placebo effect.
I think another example that I can think of about medical reversal is the Tylenol case. Until a few years ago, Tylenol was the standard over-the-counter drug for treating fever and pain. I recall all of the TV ads that stated that it was recommended by doctors more than any other similar drug. And I believe that those claims were true at the time, that doctors were recommending it. But then suddenly, almost overnight, there are no Tylenol ads on TV, and I've been advised by my own doctor to not take Tylenol for pain or fever, to take ibuprofen instead. So first, is this the kind of thing that you're talking about, medical reversals? And next, what happened to Tylenol? Was it good and now it's bad? I mean, the drug didn't change, right? What happened?
That's a good question. So I guess that's the sort of thing I am talking about when it comes to medical reversals, those kind of flip-flopping advice. And you had asked a little bit earlier, which is why your title of the book is Ending Medical. Why do you want to end it? And I guess the idea is that we don't have to flip-flop so much. We could have lessons that are more enduring, and we need to have more consistency in medicine, which means that sometimes we have to refrain from making a recommendation when we really don't know. Sometimes the answer is we need to sort this out. We need to learn rather than you ought to do X, Y, or Z. And we need a culture in medicine that allows for that uncertainty and has a way to sort of self-correct. Now, the example you give, I think, is part of a longer history. There's certainly Tylenol, there's Advil, there's aspirin. And over the course of your life, we've flip-flopped a lot. You know, aspirin was once widely recommended in young children, only to discover this rare syndrome called Ray's syndrome, where it was found to be a little bit risky. Then we moved to Tylenol. And now I don't know for sure, but I suspect maybe some of the advice you're getting because your doctor might be worried that you'll be masking a fever, that actually by taking Tylenol, you might be getting sick, but you wouldn't know it because you couldn't mount a fever. Maybe that's why.
It could have, but I believe that they've now the medical establishment has determined that it's not a great drug for your liver.
And then the other thing is, how much can you take safely? Used to be 4,000 milligrams a day. There's some people say it should be 3,000 milligrams or 2,000 milligrams. So it does have the liver toxicity. And Advil has another toxicity, which is on the kidneys. So, you know, it seems like sometimes there's no free lunch in this business. But I guess the question in all these situations is, you know, when the doctor does recommend the pill, what supports that recommendation? Is that the sort of evidence that's going to be durable? Is it going to be true today and true 20 years from now? And the reason we get into trouble is so often we get over our skis. We are making recommendations when we haven't really done that sort of hard-hitting work beforehand. I think the stenting is a good example of that. Why it's plausible. It has good pathophysiology. It has this short-term reinforcement. That is a nice package. And then the study that kind of disproves it is a very large, well-done, randomized study. The sort of thing that go into these Cochrane meta-analyses that we might talk about. And that's a much higher level of evidence. And then the question I have and the question we have in the book is, well, why did we wait so long to do that? We could have done that 20 years ago. Why did it take us 20 years to get around to doing that study? And I think that's kind of the thesis of that book.
Understood. You have written and spoken frequently about the COVID pandemic and our government's response to it. So I'd like to spend some time digging into your views. It's been more than 2 years since the pandemic began, and I still see people wearing masks. I assume that it's out of fear, which was induced by the media and the government constantly reporting on the dangers of COVID. For well over a year, Dr. Fauci, who headed up the NIH, persisted in insisting that repeated vaccines were needed for everyone, and he pushed for vaccine mandates in our country. Back in May 2021, Dr. Fauci said, and I'm going to quote, "When you get vaccinated, you not only protect your own health and that of the family, but also you contribute to the community health by preventing the spread of the virus through the community. And in other words, you become a dead end to the virus." End of quote. But a very recent paper published last month in the journal Cell Host and Microbe showed that Fauci was mistaken and perhaps deceptive in his statements. But a very recent paper published last month in the journal Cell Host and Microbe showed that Fauci was mistaken and perhaps even deceptive in his statements about the effectiveness of the vaccine. And very recently, he actually acknowledged that there has always been good scientific reason to believe that vaccines against respiratory viruses, similar to the ones that cause COVID, would provide limited protection against infection, and then only for a short time. And in addition, it's recently been disclosed that the vaccine does not stop the spreading of the virus from vaccinated infected people to others. The claim that it would stop the spreading was the entire reason for the mandates. Remember the phrase, "You protect me and I protect you." The vaccine mandates and the shutting down of our economy didn't have any significant effect on the spreading of the virus, I checked the statistics and I found that the death rate from COVID in Florida, which had no mandates and didn't have shutdowns, was lower than Michigan, which had mandates and rigorously enforced shutdowns. So there was no benefit from those extreme measures, but there were significant drawbacks. Thousands of people were laid off because of the shutdowns, and many more were fired for refusing to take the vaccine. And I haven't even mentioned the adverse effects of the vaccine that we're now reading about. So, Dr. Prasad, as an expert in both epidemiology and biostatistics, what's your take on all of that?
That's a good question. And there's a lot there. And maybe we'll start with the mandates first. So I think many of your points around vaccine mandates are incredibly accurate and true. Vaccine mandates were principally administered in third and fourth quarter 2021, at which point it was apparent and obvious from incidents like Provincetown, Massachusetts, that vaccinated people could spread the virus.
It was obvious that early.
Right. By the summertime of 2021, it was apparent to all. Mm-hmm. We can talk about in a second how it might have been apparent earlier. Okay, that's an evidence failure. But by the summer of 2021, it was apparent vaccinated people could spread the virus. I don't think there was much uncertainty about that. Yet the mandates happened after. I think this is problematic. We can debate, well, let me put it this way. An ethical prerequisite to mandate is you can't tell me to take my blood pressure pills. I can't tell you to take your cholesterol medicines. That's an individual healthcare choice. Mandates come into play where your health behavior might affect others. That's a prerequisite. If it doesn't affect others, then there's really no government case to compel a medical therapy. That's sort of a long-standing principle of medical ethics in this space. Mm-hmm. So my first argument is that they failed to meet that prerequisite and ergo it was unethical. The second argument is a practical argument, which is even if it could stop transmission, was it a good policy? This is a very divided country. And for every time you do something, there's an unanticipated response. Mm-hmm. A mandate might encourage some people on the margin to get vaccinated, but the downside is you may push people out of the labor force. And that also has health consequences when people aren't able to work or get pushed out of a sector. It also has political consequences. What do angry, displaced workers do? And I had written many op-eds in 2021 arguing strongly that we should not use that coercive pressure. It might be a mistake to do so. And now I think it is a mistake. Now, back to the question of when we knew we couldn't spread. So I think what Dr. Fauci is saying in the most recent editorial is we know that recurrent coronavirus infections is the norm for the other 4 circulating coronaviruses. You have a cold as a child and you get it again when you're an adult. Mm-hmm. So I think one might think it would be implausible for a single SARS-CoV-2 vaccine to have a durable protection against transmission. So I think that's what he's saying.
Because the virus changes.
The virus changes. Right. And we know that even infection doesn't have a durable protection against subsequent reinfection. Mm-hmm. Okay. So what do I think the failure was here? Now, we were spending tens of billions of dollars on Operation Warp Speed, trying to get this vaccine developed quickly. In that randomized control trial that Pfizer ran, they randomized 40,000 people to vaccine or the saline injection to try to see, is the vaccine reducing symptomatic SARS-CoV-2, so SARS-CoV-2 with symptoms. Now, in that study, the FDA could have asked Pfizer to, Fauci could have compelled Pfizer to, government could have made Pfizer do one thing in that study, which is that for some sample of people in that study, we're going to ask you, let's say you're a participant, you will swab your nose every day for the next 100 days, and people in your household will swab their nose too. And now suddenly we would be able to use the same study to tell us, could you actually have the virus and transmit unbeknownst to you? Mm-hmm. We could have demanded those. We didn't do those studies. Mm-hmm. Okay. So those studies might have cost a little bit more money, but if you're going to go out there and
inject the entire population in the United States, basically, and mandate it.
And throw people out of a job.
Right. Mm-hmm.
And let's talk about the mandate a little bit further. They fired not only people who refused to take the shot, people who have had and recovered from COVID and then refused. They fired professor at UC Irvine. He had and recovered from COVID. He's the head of the ethics department, and he was fired over it.
He was fired he had COVID, and I think all the statistics are that if you've had COVID, your immune response is much better than if you just got the shot. So he already had immunity for a certain amount of time until the virus changes. But the COVID shot would not work against new variants either, right?
It's the original Wuhan strain. And further to the point, I would say in the last 3 weeks in The Lancet, it has been demonstrated without a doubt that having had and recovered from COVID was at least as protective as being vaccinated. Mm-hmm. And both the vaccinated person and this professor who had prior COVID, they both could potentially spread it again. So I would argue that his firing was unjust. Mm-hmm. He was wrongly terminated. I think he should be rehired. I think he should be given an apology because part of building trust back is to apologize for mistakes. He should probably be paid back. So if your point about the mandate, I think is an important point, which is that it was a tremendous use of government power. And it turned out
abuse of government.
And it turned out to be an abuse because I think it was an abuse at the time. And I said as much. I said, don't do it. I had urged them not to. I think that they felt desperation in that moment. And then the temptation when you feel desperate as a bureaucrat is to use the powers you have. But it was mistaken. It was mistaken by traditional medical facts and logic and ethics. And now in retrospect, I think it was a big mistake because we see right now confidence in other vaccines is eroding.
Right.
And that's an unanticipated consequence that some of us saw coming. Mm-hmm. So to be, heavy-handedness has a place and a time, but you really need to be sure. And I think this was a bad gamble. Okay, now back to the lockdown was your second point. On the lockdown, Dr. Bob, I think it's a very, very tough question. I think your point is well taken, that it does not appear that places that locked down hard with a lot of government restrictions, places that didn't lock down much like Florida, or places that really didn't lock down at all like Sweden, it doesn't appear that there are huge differences. Mm-hmm. But to really tease apart the impact of the 10,000 different things that we did, I think it's going to take 20 years of work. I mean, it's going to be an open project to know, did these interventions help? But I will say a few things. One, voluntary behavioral change is very powerful. You don't need to force people to stay home. When people are scared, when they see cases climbing, they'll stay home. People take precautions without any coercion from government. The next thing I'd say is that it's clear that many of the things we did were just crazy. We put chains on playgrounds. We took
arrested people coming out of the water and the beach in San Diego.
You have a professor at this university who is quoted in the newspaper as urging surfers not to surf. So that was the level of hysteria at the time, panic. We closed beaches. We took basketball rims off the hoop. We told people to be sedentary, to stay home. We did a lot of things.
And we kept people with medical issues from going to the hospital because there were no appointments available. It was only reserved for people with COVID.
So we had poor management of high blood pressure, of heart disease, of all the things.
Cancer treatments.
Yeah. And I think to your point, which is that, and we closed the schools and we destroyed a generation of kids' future. You haven't paid that check yet. We made that choice, but we haven't seen the full implications of what it means to close schools for so many kids for so long. That's something we're going to be paying for the next 40, 50 years. So your point about lockdown is well taken. I was incredibly skeptical.
And we're still seeing the effect because people were told you can work from home. And we're about 2.5 years after COVID, and people still are refusing to go to work full time. They want 3 days off or 3 days at home or 2 days at home. But most companies aren't forcing people or aren't benefiting from people being in the office where, frankly, they are more productive. So we're still seeing the effect of these lockdowns in the absentee rate for people not showing up for work.
And I'm not sure it's necessarily in the best interest of the person staying at home. I know people feel like I'm 20 years old and I want to stay in my apartment and it's easier than going to work. But staying in your apartment alone is not good for your anxiety, your depression, and your life. You need to get out there and actually participate in society. So I think you're right. That's another implication of the lockdown. It's accelerated those trends. I think the mandate, I'm happy to say, was a bad idea in the beginning, and it's bad now, and it's bad, and I'm happy to put that issue to rest. The lockdown is a more complicated issue that will take decades to unpack. My intuition is that, we did a lot of bad things. And, it's a tale as old as time. When someone is scared, they can mutilate themselves. Out of fear, they can make choices that only hurt them and don't solve the problem.
After 2 years of misinformation and the censoring of contrary opinions about COVID and the vaccine, has the American public lost faith in both our government and the medical establishment?
I think the answer to the question is yes. You see incredible polarization around public health. You see incredible distrust of institutions. And I want to say that they deserve some of that distrust. I mean, I think that's important to acknowledge. I do think it is important in the long haul that we all have some trust in institutions and government. We have to. But when trust is spent like monopoly money, it's natural that people will no longer trust the institutions. I think many of the examples of why we failed were people overstated evidence. We did that around vaccines. We did, because we
and
did.
They overstated the
masks.
deaths too, from what I understand. As I understand it, hospitals were paid a certain amount extra for COVID, for reporting COVID things of COVID nature, like deaths from COVID. So they would therefore bias if somebody came in with a heart attack and also had COVID, they'd list it as a COVID death. Did that happen too?
I would say to put it in the most accurate way is that Medicare provided an extra reimbursement if COVID was also a condition for which someone was getting care. But the consequence is you can't give someone COVID if they don't have COVID. Okay, so they're not doing that. But it incentivizes them to look very hard. Okay, so they're incentivized to look very hard. Now, what might that do? When you start talking about these statistics, we often compare deaths from COVID in the U.S. versus other countries. The problem is not all the other countries are testing the same way, or documenting the same way, or reporting honestly. When I see a statistic out of China, I have 0% trust that that's an accurate number. When I see a statistic out of Western Europe, I don't know if they're looking as hard as we looked in the U.S.
Yes.
So it's not to say, I think it's not to say that people are fabricating numbers. It's that everything in life is a matter of incentives. When you're incentivized to look very hard, you will look harder, and your number may not be comparable to someone not incentivized very hard. Now, it does have implications for trying to think through the data on this issue. Yeah.
And do you think the government has learned anything about how to respond to future pandemics?
Not good lessons.
Right. That's my belief. Not good lessons.
I think the reason that they largely feel vindicated is that, in my opinion, the bulk of the errors occurred in 2021. It was errors that were made post-vaccine in the rollout and things like that. They were vindicated by a midterm election that they felt favorable. So I think without that political pressure, they probably feel vindicated, and they have not learned lessons. I think.
I think they learned that they can have mandates whenever they want. Now, here are 2 points that prove that the current administration has learned nothing from the misinformation in the past 2 years. Point number 1, the public health emergency that was announced at the start of the pandemic in early 2020, you may not believe, maybe you know this, most people don't know it, the public emergency is still ongoing. In effect.
Yeah.
Now, Biden recently announced plans to end it on May 11th. Why end it then? Emergencies don't last 2.5 years. And point number 2, the second issue, which shows that our government has learned nothing about how to deal with pandemics, is that it's been reported that President Biden is negotiating an agreement to give who? The World Health Organization authority over U.S. pandemic policies. It was who got us into those terrible lockdowns in the first place. Why on earth would we want an outside body of bureaucrats to determine America's health policies, especially one like who that is prone to influence by China?
I guess I would say that the initial lockdown was driven by, in my opinion, several factors. One is a very scary report from Imperial College London that I think was inaccurate. Number 2, one of the rare instances where Western free democracies took lessons from totalitarian communist regimes because we learned lockdown was an option from them. 3, I think it is also linked to the death of D.A. Henderson, who eradicated smallpox. He's a very prominent public health figure. He had died prior to the COVID-19 pandemic. He was, I think, in his 90s. Why is that important? I think he fundamentally would have opposed such a restriction. you had a confluence of factors. You had people who happened to have the ear of the White House. Of course, Trump was president at the time. You had a very fearful report that came out of London. You had horrific stories coming out of Lombardy and Wuhan. It's the stories of near hospital collapse. And politicians, when they fear a situation, they don't want to be seen as weak. They want to be seen as reactive. Mm-hmm. And somebody's whispering in their ear, you're going to have 1 million dead people if you don't do this right now. Mm-hmm. That was a tough decision. Now, some politicians, I think, were quick to realize the error. So I think DeSantis is one. Within 6 weeks, DeSantis said, I think perhaps we've overreacted. He was getting some different opinions. He was the first to reopen schools in the spring of 2020. Mm-hmm. He quickly took away any restrictions on businesses. And as you point out, Florida does not appear to have done age-adjusted, per capita adjusted, much differently than other places, even like California. Now, your point about turning over the authority to WHO, I think would be mistaken. I think that one of the challenges the pandemic revealed is what is the job of a scientist and what is the job of people? The scientist's job is to tell you what the trade-offs are. If you choose this treatment, what's the pluses and minuses? If you choose no treatment, pluses and minuses. If you choose to lock down schools, pluses and minuses. I can tell you how many kids will lose a year of education and how many, I can tell you those things. But it's not the job of the scientist to make the decision, should we do that? Mm-hmm. That's a decision that only people make. And the electrician's opinion is as important as the doctor's opinion. It's a societal decision. And so I do think those decisions have to be made by politics. That's a political decision, how you choose to act upon trade-offs. I think that scientists took away the choice from people through this pandemic, through misleading messaging, being overconfident, and falsely articulating the trade-offs. If I tell you if schools were open, all the kids would be dead, you would say, close the schools. But if I told you the reality that the risk to kids is so very, very low and the risk of closure is so very, very high, you might choose differently. My job is to tell you the honest truth, but only people can make these votes.
Well, it seems like the politicians and certainly the media were amplifying the negatives and never spoke about the other side of the medical issues that we're now reading about.
Can I say one thing about the media? We talk about the media. These are people who, and I want to say one thing, which is I don't think anyone working in the hospital is ill-intentioned. I don't think people working in the media are ill-intentioned, but we have to acknowledge their role. If I have a kind of job where I can work on Zoom, I will never be fired. I can do my full job on Zoom from the comforts of my home, having Uber Eats deliver me food, which most people who work at Washington Post and New York Times and CNN have that luxury. I'm not the same vantage point as someone who's a truck driver, who works in a slaughterhouse, who has to go work the field, who has a job where you have to show up in person. You can't phone that in. You can't do that on Zoom. And so I do think the media has had a warped view of COVID because they have a job where they don't have to go anywhere.
So it's good for everybody. That's what they're thinking.
Correct.
A couple more questions about our response to COVID. During the first 2 years of the pandemic, we were all told to wear masks and to maintain a 6-foot distance from other people. It's a 3-part question. Do masks prevent the wearer from getting COVID or any flu-like virus that affects the respiratory system? And secondly, do they prevent the transmission of COVID from an infected person to anyone else? Does it stop the spread from the person wearing the mask? And does it stop the person wearing the mask from getting it from someone else?
I guess I'd say the answer to these questions are...
and there's a new study that you can speak to about masks.
Yeah. So I want to say, I'll talk about the study in a second, but one of the things I want to say is the great failure of the pandemic is that throughout this pandemic, people spoke on this issue with such certainty when the reality was it was always very ambiguous, and they also never did any studies. Anthony Fauci runs NIAID, the branch of NIH you spoke about. He has a budget of multi-billion dollars, and that entity chooses what studies to fund. Mm-hmm. There's no one better suited to decide what to fund than this gentleman. Within a 6-week period of time on 60 Minutes, he has 2 interviews, one saying they don't work. That reflected the pre-pandemic body of knowledge, including multiple randomized trials of respiratory viruses. When he spoke the first time on 60 Minutes, I think he was telling what he believed to be the truth, that there was no evidence that community mask recommendations would slow the spread of a respiratory virus. And we don't know if there'll be compensatory behavior, like I think his quote was touching your face or something like that. I think he was telling the truth then. 6 weeks later, he goes back and he's a new message where you ought to wear a cloth mask. Remember, he didn't say surgical mask. He didn't say N95. He said a homemade cloth mask.
Homemade cloth mask.
The evidence at the time already suggested that would not work, wouldn't do anything. And I think he knew it. So I think, he always tells the story that I lied the first time to protect the healthcare workers' supply. I think the true story is he lied the second time because I think he felt like people needed something, a panacea, something to put some of their anxiety on. And of course, it quickly became a visible symbol of political allegiance because Trump famously didn't wear his. And whatever he doesn't do, to some people, the opposite is the right answer. That's how they practice science. Now, what is a recent study? Cochrane, very well-respected body of evidence. They looked at all of the randomized control trials of all physical interventions to prevent respiratory virus spread. So both masking, but also glasses, also hand washing, any physical intervention. And they concluded that across a dozen randomized control trials, there is no persuasive evidence that masks lower the rate of COVID-19 transmission, either to the wearer or to the other person. There's just no persuasive evidence that is the case in adults. Keep in mind, in this country, we were pushing it to 2-year-olds, where I think not only is there no evidence, it's also a little bit crazy to think that a 2-year-old chewing on a cloth mask is going to work. And then they take a nap next to each other and they take the masks off so they can nap. So they sit in the same room for 2 hours. So I think we were getting absurd, and it has taken on sort of a religious kind of fervor around it. In part, the people wearing the mask today, they're typically not, to my eyes, the oldest and most vulnerable people. They're often very young people because it is a badge of, I'm a young, progressive person who cares about other people. But to me, that's not how you practice public health. You really need the best evidence. The best evidence, and I published a paper on this about a year ago, suggests that probably doesn't do much, probably doesn't do anything. And there's certainly no reason to think it does. And there is really no justification for mandates. And I'll make one last point to you, Dr. Bob. To me, after the vaccine was offered to Americans, after you offer by May 2021, I think masking made no sense. Even if you were somebody who believed it worked, nobody believed it worked 100%. It's got to be 5%, 10%. Even the believers, and I'm not one of them. I actually think it probably is close to 0 in community practice. But if let's say you believe it works 5%, if you're going to wear it for 20 years, you have a 100% chance of getting the virus. I mean, you have to live life.
I understand.
Right. So maybe it works for a few months, a few weeks in short-term situations. But what is the justification for doing it year after year? It's bizarre, and I think it's illogical.
Bizarre, especially now when nobody is getting COVID, from what I understand. At least the emergency rooms aren't filled with COVID patients. Am I correct?
Yes, they're not filled with COVID patients. And additionally, most of us have already had COVID. I think the seroprevalence is the vast majority of Americans. And in children, we're talking about 86% seroprevalence at last CDC estimate. Probably by the time this podcast airs, 90+%. So we've all had it anyway. I don't know what we're trying to avoid. The question was, how many vulnerable people could you make sure got COVID after vaccination than before? We're talking about vulnerable and older people. That's the real sort of policy question. All this stuff is too much.
And actually, I had a box of masks, and I read at the bottom, and it said in plain English, these masks do not protect you from any disease. I couldn't believe it actually said it right on the mask. Okay, next. What's with the 6-foot criteria that was being enforced in most places? Do COVID viruses get tired and fall to earth after traveling 5.9 feet? Is that why you stand 6 feet away?
I think that was an unfortunate example of something that was absolutely invented. And I think there are a number of commentaries, I think one in Vox, where they explain the origin of it.
There is an origin or a presumed origin. Somebody came up with it.
It's 100% fabricated. It has no science behind it. It's illogical. It reflects poorly on us, to be honest with you. If you're going to tell people to do something, you can't include things that you just made up. I don't think you have credibility.
It was just made up.
Yeah.
Well, I recall during COVID that some restaurants were still open in San Diego, or maybe it was COVID was waning, so they opened restaurants. But you weren't allowed into the restaurant unless you had a mask on. Now, as soon as you were seated, you could take the mask off. So it seems to me there's some tendency of the COVID virus to work above a 5 foot and below 5 feet. When you sit down, you're below 5 feet. So it's sensitive to I think altitude. That must be the case of why you can go. You had to have the mask to go in and sit down, but then you could take it off when you're at your table.
But when you go to the bathroom, you have to put it back on for the walk to the bathroom.
For the walk to the bathroom. But it's the same air.
And the waiter has to always wear his mask.
Right.
I mean, what you're pointing at are these absurdities, which I think were not adequately dealt with. When you have absurdities like this in policy and you really want people to trust you, you can't have it. You have to have policies make sense. It didn't make sense. Your point is, you don't need to know anything about masks. You don't need to be a scientist to know. Why would I do this from here to the door and then sit at the table for 2 hours? You don't need to know. I had a friend tell me, he's a famous researcher in Europe, and he said, you don't need to know any science to know masking a 2-year-old doesn't make sense. You just need eyes and ears. And I think that's why Americans have lost trust, because you had policymakers enforcing these policies. What do they think of the American people? Do they think we're stupid? I mean, that's the only conclusion.
Yeah, so I wasn't wearing a mask most of the times during the pandemic. And one Saturday, I went to the local hardware store to pick up some nuts and bolts or whatever, to fix some things around the house. I'm sort of handy. And there was a sign, you have to have a mask on. I didn't. I ignored that sign because I just don't believe in masks. And I was proven to be right, of course, a little later. But at any rate, so I went into the store and I'm standing in line to check out. And I'm trying to be a good citizen. I'm 6 feet away from the guy who's in front of me who happened to be wearing a mask. Now, I know that because he was right at the checkout getting ready to pay. And he turned around and noticed me. And he said, "Hey, you got to put on a mask." I said, "Oh, why's that?" He said, "It's an order." I said, "I'm not in the military. I don't follow fucking orders." And that's the case. I think the worst thing that happened during the pandemic is that people became automatons. Suddenly you heard about executive orders. I mean, I've been an American. I've lived in this country all my life. And only during the pandemic did you start hearing about executive orders, not just from the President of the United States, but you heard them from governors, from mayors. So all of a sudden got this power to issue executive orders. And I understand if there's a crisis, we're being attacked by Martians, the people in charge have to take charge and issue executive orders. But that should only last for about a week, maybe. Right? An executive order. But suddenly the mayors and the governors of California were issuing all of a sudden executive orders, and the police were following them out as if they were laws. We agreed as Americans to be governed. We didn't agree to be ruled. So I think that's one of the most upsetting parts of the pandemic to me, was that people were willing to follow orders rather than laws. Getting back to
Can I comment on this?
Oh, yeah, please.
I mean, I really agree with you in a profound way, which is public health in my mind was not meant to be enforced by the police state. That's antithetical, I think, to the principles of public health. And the moment we enter a world where public health principles are enforced by police or military force on the citizens of a nation, you're in a dangerous place. You're also in a dangerous place when you allow politicians to decide for themselves when emergencies begin and if they ever end. And they decide for themselves what powers they have. And the potential for abuse has got to scare everybody. No matter where you sit in the political spectrum, you've got to worry. Think about the person you don't want in power when they declare an emergency. There has to be some checks on this system. And I am deeply concerned that public health and the police force was not how it's meant to be. In my opinion, as somebody who is an MPH and sees himself as what public health meant to me, when you see a situation where people are dying of a preventable condition, you go there and you offer resources to help people make choices that help them reach the goals they want to avoid this preventable condition. You support them. You give resources. You don't place restrictions on them, and you certainly don't get the police to beat people, to put them in handcuffs, to pepper spray them. That's not what public health was ever meant to be.
Again, I recall seeing it on the news and seeing the photographs of 3 police handcuffing a guy who's sitting on a blanket at the beach.
Yeah.
And nobody was there.
I know.
Handcuffing.
In many nations, in Australia, in this country, it's
abuse of power.
It's distressing to free society. It's a real threat. I don't think people appreciate that. That's not how you should police respiratory virus. And let's just talk philosophically. Why do the respiratory viruses exist? They exist because it's who we are. We have to be close to each other to be human beings. It's a dumb virus. It's taking advantage of an evolutionary niche, which is that people, to be people, have to be close.
Right.
We have to breathe the same air. That's who we are. Right. And you're using the police force to deny people the right to hold the hand of their father when their father is dying.
Right.
To see their son when the son is getting chemo in the hospital. To go to the beach. To walk outside with a friend. I've never seen the police used like this in a free democratic society.
It was very rare for a police force or for a sheriff to say, "I'm not going to enforce those rules." I remember there were a few, but most of the cops or whatever went out and they're worrying about their pension or getting fired, I suppose. So they enforced the rules and arresting people on the beach. Getting back to the age of people and their likelihood of getting sick, I've read that young people younger than 25 who are in good health are at a very low risk of getting COVID. And according to the data that I've seen, even if they do get COVID, they have very mild symptoms or none at all. So given that, what is the stated rationale for masking kids or healthy young people? They're still in force in many school systems. The kids have to be masked. What is the rationale given that we have the data that they don't get it, or if they get it, 0 or no symptoms?
I think it's a great tragedy that children were punished by these pandemic policies. The risk to a 5 to 11-year-old was always on par with or lower than seasonal influenza. We've never closed their schools for 18 months for seasonal influenza. We wouldn't do that. Now they're masking kids. You're right. Kids have nearly all already had COVID. Maybe a third have also had a vaccine dose. What are we doing? This is assuming it actually slows the spread, which I'm not sure it does. And what's the long-term goal? To what end? Because there were many schools that had masks policies 2 weeks after winter break. Are we going to be doing that in 2040? In 2045? Meanwhile, simultaneously, we are not generating evidence. We could be running studies. You could take 100 schools and do it, 100 schools that don't. And I promise you, in 6 weeks, you'll learn. And my guess is I'll bet every dollar I own, you'll learn it doesn't do anything. But we're not doing that study. So you have people who are proponents of this policy, which is supported by very weak evidence, runs counter to common sense because the kids have had COVID anyway, and they're instituting this in forever. That's problematic. I think it's problematic from a scientific reason.
So what data are they using to justify it? Because all of the reports that I've read, and a most recent one was even, I think, alluded to in the New York Times, which was very pro-mask. And there was a big op-ed or an editorial in the New York Times just in the past few days saying masks don't work.
By Bret Stephens.
Right.
And he's a brave person, and it was a smart editorial. But what you see, Dr. Bob, is the pendulum on this issue is swinging. You know, a year ago, this conversation would have been considered more provocative than it is now. And 3 years from now, it's going to be considered very different than it is in this moment. The pendulum is swinging quickly because, yes, when people are scared, they will make bad choices, but no one can stay scared forever. And eventually the reality sets in that, as you point out, for young people, this has always been just one of the many risks they face, including suicide, gun violence, homicide, the risks of growing up and having a healthy and productive life and being a productive member of society. These are all the challenges they face, and COVID was just one of them. It's different if you're 85. I think COVID was a serious risk to an 85-year-old, especially somebody in poor health. But to the children,
so isn't the flu.
And so is the flu. And a lot of things are, to older people. But to children, I think this was always exaggerated. I think we saw terrible things. We saw their schools closed. We saw parents who didn't let their child play with another child for years. You know, very dark things. And this is all a product of a media that's been revved up on this. that Bret Stephens piece is a seminal moment because it's a crack in the New York Times, which was one of the most restriction-centered newspapers in this country. And I suspect what will happen is in 6 months, there'll be 3 more. And in a year, there'll be 10 more. And in 5 years from now, I think we will look back on the COVID-19 pandemic as the way we look back on an unjust war.
Unjust war, right,
Yeah.
against people. Now, I was diagnosed with COVID twice in the past 2 years. The first time, I was treated early on with an infusion, and all of my symptoms, which were mild, disappeared in 2 days. The second time that I had COVID, I was given Paxlovid, and again, in 2 days, my symptoms disappeared. But recently, I've read articles that say Paxlovid is not effective in treating the symptoms of COVID. So what's the story with Paxlovid? We're told it works, and now we're told it doesn't work.
It's a good question. So I would say that if somebody is unvaccinated and they've never had COVID and they have a risk factor for progression to bad outcomes, like being older or have high blood pressure, Paxlovid dramatically lowers the risk of hospitalization or death. There's a randomized trial called EPIC-HR that supports that claim.
And that's taken after symptoms. You don't take it previously.
After symptoms. There is a trial of people who, if you had COVID and I exposed myself to you, it's called post-exposure prophylaxis, PEP, PEP, post-exposure prophylaxis. That's a negative study. So actually, if it turned out that you had COVID, I go home and somebody tells me you had COVID, should I take Paxlovid? I feel fine to avoid getting it. The answer is it doesn't work there.
Doesn't work.
If I'm vaccinated or boosted or double boosted or triple boosted or quadruple boosted, as some people are, if I'm in that category, what evidence do we have that Paxlovid works? If I'm under 50, if I'm 20 years old, what evidence do we have? And the answer is we don't have great evidence. We have a negative study by Pfizer called EPIC-SR. They've never published it. We have an ongoing study in the United Kingdom called Panoramic, and it's going to be published soon. So we don't have great evidence in people who are vaccinated, younger, healthier, those populations. We will get the answer. The UK have randomized tens of thousands of people, so they will definitely deliver an answer
On Paxlovid.
within the year. But my concern is the following. This administration spent $5 billion on this product before they'd seen the results. Then they spent another $5 billion on this product, and they are heavily incentivized in getting this product used. If this product turns out not to work in vaccinated or boosted people,
$10 billion wasted.
and it will be reminiscent of other products. We used to stockpile Tamiflu, a Roche pharmaceutical product for influenza, and it was later found in a meta-analysis by the same author as that Cochrane meta-analysis, Tom Jefferson, that Tamiflu actually is an incredibly marginal drug for flu. It does very little, if anything at all, and it doesn't really prevent hospitalizations.
And it's expensive.
And it's expensive. Governments around the world spend tens of billions of dollars stockpiling it.
Ooh, I've stockpiled it, right. And it's marginally effective in reducing the symptoms of flu.
Correct. I think this is a BMJ paper that shows the symptoms of flu are shortened by about a day, but the first day you have a little more nausea. There's no reduction in ventilator use or death.
Oh, this is a very revealing conversation. So now during the pandemic, there was a doctor, Zelinsky, and there was the Zelinsky protocol of zinc and ivermectin or something or other. And he treated supposedly thousands of people. Was that something that, and I think President Trump actually took that protocol. What do you think of that as a possible treatment?
So this is the one place that maybe you won't like my answer, but I would say that I'm generally a skeptic of all of these treatments. And why am I a skeptic? Because I feel the burden has always been that whatever treatment you have or offer, you need to prove to me, how do you identify the right group of people to take it? And what do you give? And what do they gain from it? And I think I have yet to see any evidence that some of those medicines or a cocktail of those medicines work. And I think that, people who really believe in masks, they have a million reasons why they don't like the Cochrane mask study. And people who really believe in medicines, they have a million reasons why they don't like a medicine study. But to me, the burden is you show me how it works and I'll be sold. But I've yet to see that.
I see. Okay. All right. So there's essentially the feeling that you have it evidently is that there's no particular treatment for COVID right now.
I guess the treatments that I do think have evidence are Paxlovid in unvaccinated people at high risk, as I mentioned.
Okay.
Dexamethasone works, I think, if you're COVID and on the ventilator. We have some data for a small role for remdesivir and tocilizumab, and there's a couple other smaller drugs. So there's a few drugs that I think have some role in the hospital setting.
In the hospital setting, sure. Right, I see. Okay. Mm-hmm. Changing the topic, let's talk about different prescription drugs. Now, I don't watch TV too often, but when I do, typically when I'm traveling, I'm at a hotel because I disconnected my cable box here and I just don't want to watch TV anymore. So when I do travel and watch and TV's on, I see lots of ads touting the benefits of new prescription drugs for treating virtually every ailment from cancer to diabetes. These ads always show healthy-looking, smiling people playing tennis or cooking, or more recently playing frisbee with their dog, while at the same time, near the end of the commercial, the audio, in a lower tone, lists all the possible downsides, including death from those drugs. Now, maybe the cable providers target me because I'm in the population of people who are likely to get sick. That means, sort of older people. So I understand the rationale. And I also understand the rationale for advertising over-the-counter drugs because you can influence the person to go buy those drugs. So to advertise over-the-counter drugs. But why is it legal or proper to advertise something that can't be legally obtained by the viewer without a prescription? Why is it legal? Why is that allowed?
You're asking a good question. Direct-to-consumer advertising pharmaceutical products, to my knowledge, is only permitted by two nations, the United States and New Zealand. And it's banned throughout most of the world for the precise reasons you say, that one, it still requires the gatekeeper of the doctor. Two, what is the average person to do with this information? I've seen ads on TV that say, ask your doctor if you have non-small cell lung cancer with the PD-L1 expression of over 5%. Really?
Remember that?
Yeah. Right? So,
but it must be effective because they're spending money on those ads.
Correct. So they have ROI.
Right.
So in order to they would not spend the money if they were not making a return on investment. And how do they make the money? By you watching the ad. Out of 1,000 people who watch, one will go to their doctor and say, hey, I got to ask you about this ad I saw. And out of 1,000 people who ask their doctor, maybe one will, and that money is worth it to justify the whole campaign, right? So they must be making money.
But if people are ill, shouldn't they go to their doctor and ask the doctor what they recommend rather than ask them to write a prescription for what a friggin' TV commercial recommends? Isn't that the right thing to do? I wouldn't go to the doctor and ask for something that I saw in a commercial. I'd say, what do you recommend? I might then mention, what about this newer drug that I've heard of? But it wouldn't influence me to get that drug.
Yeah, I think what you're getting at is sort of the view of the doctor-patient relationship that I have, which is you need to find somebody you trust in. And trust somebody means you trust their judgment, that they're going to recommend what's right for you. And if you have to be cutting out ads from the newspaper to teach them how to practice medicine, it seems a little odd, if you ask me.
Okay, let's talk about cancer. 3 years ago, you wrote and published a book entitled Malignant: How Bad Policy and Bad Evidence Harms People with Cancer. What's the current policy on cancer treatment, and why is it bad?
Well, it's a good question. So I would say, what's bad about it? One, I would say, what is the policy? There are many, many policies. There are many, many payers, and it's a very complex system where money flows in many directions. And the goal of the system is for people with cancer to have their lives be extended, to have the cancers cured, to live as long as good in life as possible. And this book is really an exploration of the many thousand ways in which we don't deliver on that. Yes, we have great drugs. Yes, we can cure patients with cancer. Those are great things. But the average drug that we put on the market improves survival 2 months. That's the average drug. The average drug now costs $200,000 a year. There are people who go into bankruptcy because of medical bills and having a diagnosis of cancer. Meanwhile, there are things we don't do. If somebody has cancer and comes to my clinic, so often I can easily give them $200,000 worth of medicine. But if they ask me for some help around the house to do the dishes or to have them get out of bed or help go to the bathroom, that's really difficult. So there are things we do put a lot of money into, pharmaceutical products typically. We don't put a lot of money into caring for somebody. So this book is a meditation on this whole system. It really asks us what do we want for people with cancer, and where is the system broken? And as you might imagine, I think a lot of the broken systems at the federal level. There's a lot of federal programs and a lot of federal restrictions that don't lead to the optimal outcomes for cancer and feel as if it's designed to lead to the optimal outcomes for the pharmaceutical companies.
Mm-hmm. And often, from what I've read, what many of these drugs or procedures do is may shrink a tumor, but shrinking a tumor doesn't necessarily mean that the person's going to live longer, right? Just like
putting a mask on a dummy in a chamber and showing the aerosol spray is less doesn't necessarily mean it works in the real world where people don't always wear it. Exactly right. Just because the tumor is smaller doesn't necessarily mean you live longer and live better. And in medicine, we call this the difference between surrogate outcomes, things that are measurable and stand-ins, and clinical outcomes, what people care about, living longer, living better.
Now, you have a record of urging fellow medical researchers to always consider the risks versus the benefits of any new drug or procedure. And back in 2013, you published a paper entitled A Decade of Reversal, an analysis of 146 contradicted practices. Based on that title, I presume that it discusses medical practices that were once considered to be proven to be worthwhile, but after further studies were removed from the market. A total reversal. Can you give us some more examples? We talked about the Tylenol being one, but do you have any others?
Yes, I'll give you some. So one is impermeable bed covers for people with dust mite allergy and allergic rhinitis. Let me explain this. There have always been some young people, adults, who when they wake up in the morning, they have asthma or a stuffy nose. And if you do allergy testing on some of these people, you'll find they're allergic to dust mites. Dust mites that live in bedding. And so it was very logical and intuitive. The solution to somebody with dust mite allergies is you got to take away the exposure. So let's take your pillows, let's take your sheets and put this impermeable bed cover, like a rubber sheet on it, so the dust mites can't come. And I know many kids who, when they were young, they had this bedding that when you sit on it, you kind of start to sweat because it was this rubber. So they did a very clever 2 studies in 2007, the New England Journal. They randomized people to the rubber sheets or sham rubber sheets. They poked holes in it so dust mites can move freely. And then they measured a whole host of things, including how you feel and how you breathe. And they showed that actually the symptoms were improved in both groups. It was a placebo effect.
Why would they be improved in both groups?
The thought that you were doing something.
Oh,
right.
No. So it's not that the symptoms were improved, but the reported by the
patient.
By the patient, I feel better.
Yes,
I see.
But the impermeable bed covers didn't do anything.
Right. The ones that were poked holes in, it was obvious. There was nothing different.
Another example is we have a procedure in oncology called the stem cell transplant. For some diseases, it works very well and is life-saving. But they were also doing it for women with breast cancer. Nowadays, we don't do it for breast cancer. And in the 1970s, we didn't do it for breast cancer. But between the 80s and 90s and early 2000s, we did 40,000 for breast cancer. And we did because somebody did it to 100 women, and they were like, you've never seen anything like this. They're living longer. Some people, I really think they're cured. But they didn't have a control group. It wasn't a randomized experiment. By 2004 and 5, we had 6 randomized trials, and they show that it actually doesn't increase survival. And so we flip-flopped on that. Now, a transplant, if it's something that benefits you, it's worth doing. But if it's something that doesn't benefit you, it's really a tough thing to get through.
Understood. Our last topic today is on DEI, diversity, equity, and inclusion. Now, you might initially think, or the audience might think, well, what is he asking a doctor about DEI for? Well, here's why. Turns out, I've learned that many medical schools have recently changed their admissions policies, which in the past were based primarily on merit, how smart you were, what your grades were like, what your motivation is like to be a doctor. Instead, now, race and skin color are being used as criteria, not the only criteria, but as serious, significant criteria in order to achieve equity, quote, equity. Maybe I'm strange, but when I go to see a doctor, I'm only interested in his or her knowledge, experience, and skill in determining what's wrong with me and then fixing it. Ability is what I'm looking for, not equity. And major hospitals are now requiring that their medical staff take DEI training. In that regard, I notice on your resume, under the heading Education and Training, right under where it lists all your formal degrees, I noticed that just last year was listed. You completed a course at UCSF entitled Diversity, Equity, and Inclusion Champion Training, right there under your medical degrees, as if it's the same category. So tell me, did that course help you become a better researcher or clinician? What's happening here?
It's a tough question. So I think, that that course is taken by people who teach courses in the school, which I'm one. And I guess I would say that I do think that these classes would benefit from careful study because we all experience things in our lives, hard to know what it does. But the real question you're asking, I think, is if 100 doctors take this course or not, how do they teach differently or practice differently? Or do you see any differences at all?
Yeah. Well, one thing you'll see differently is they're spending time in that class. I mean, you'll tell me how much time did you spend in the course? Not only paying attention to it, but perhaps reading. How much time? How many hours were spent?
It's probably over the course of a couple sessions, probably the equivalent of like 1.5 work days.
Yeah. So you got to compare the benefit to the general population of sick people that you're going to see. Would you be a better physician and clinician and researcher having spent the 1.5 work days there, or 1.5 work days with patients helping them get over cancer? That's really the question.
Well, I guess that's what they should, and I do think that they ought to study that. But let me push you on one thing, the merit part, which is that, and I think to some degree, I share your intuition that we all want the best doctors. But I want to acknowledge one thing, which is that I think even 25 years ago, there was a lot of uncertainty as to which 22-year-old is going to be the best doctor. Mm-hmm. And it's really surprising, Mm-hmm. I think you might think it's the person who went to Princeton, has all A's, but every once in a while it's the person who goes to Montana State University, who worked in the fry kitchen. You never know. And I think that medicine has always done a very poor job of trying to figure out who has that thing in him, just like any business, And there's something about some people. What is that thing? I think it's always being curious. It's being caring. It's always trying to push yourself. And sometimes to be a great doctor, it's stuff that nobody sees. The only person who sees it is your patient. Mm-hmm.
No, I agree that in many fields, grades alone do not determine success, and especially in medicine, where a caring nature of a person is probably more important than getting an A versus a B in organic chemistry. So I'm not saying it should be based solely on grades, and I did mention motivation, right, ambition, and a sense of caring for people. But what does skin color have to do with this?
I think that the motivation of the program is, I'm going to do my best to sort of articulate.
And I hope the audience, I hope you understand that he has a position at a major university, and most of these major universities have, woke administrators these days. So I'm sorry to ask him such a difficult question, but he'll weave it in such a way that it'll be okay for him. I'm not trying to damage his potential for growth at UCSD.
I think that I think it is a virtue that we have a doctor force that looks like the American population they take care of, across all dimensions, from religion to sexual orientation to race. And I think that's the intention of the program, is that, these sorts of efforts is so that the doctors and the patients, they're the same. They're coming from the same communities. They go back to the same communities. They look the same. They're the same across many different dimensions of diversity. including maybe ideological diversity too, along with all these other things. I think that's the goal. I think that how they go about achieving the goal, that's the tough part. And I think the questions are, you want to make everyone great. I think that's the goal of the educator. Whether somebody had a hard upbringing or every privilege in life, you want to make them a great doctor. I think we should be committed to that process. We should be able to take people and train them to be great physicians. And I think that what you see in universities is that they struggle with how to do this. And they do it in a way where they're not always kind of collecting information along the way. I'm not sure we were doing a great job in 2000. I don't know how we're doing this day. But I do think that, there is this is the kernel of their motivation of these programs.
Okay, I think the motivation is proper. Well, Dr. Prasad, thank you for spending time with me today, and thank you so much more for your continued efforts to improve the care of cancer patients and to make important changes to the American medical system, which will improve the care for all of our patients. Thank you for watching, and if you enjoyed this episode of Life Lessons with Dr. Bob, please subscribe, and you'll be automatically notified of future podcasts in this series.
Thanks so much for listening to another episode of Life Lessons with Dr. Bob. If you enjoyed these interviews with some of today's most influential thought leaders, please follow and rate the show on your favorite podcast platform. And don't forget, you can also watch each episode on YouTube as well. We'll see you next time.
Hey, thanks for tuning in. I appreciate reading your comments on YouTube and social media, and now you can submit your questions on my website as well. Head over to lifelessonswithdrbob.com and click the question tab at the top of the page or the one on the right side of the screen, and let us know what's on your mind. I'll answer your questions at the beginning of each episode, so let it rip. Let's have some fun.